The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to today's webinar, Cold Laser Therapy for Diabetic Neuropathy. My name is Dr. Rhonda Mostyn, and I'm the Clinic Director at Theralase. In today's webinar, I'm going to be giving you some background on diabetic neuropathy, and then we'll talk about some treatment protocols, and we'll hear from some patients who've had very successful treatments with diabetic neuropathy, and finally, we'll move on to some research studies in the area. So here's some background information on diabetic neuropathy. 50 to 60% of people with diabetes have some form of neuropathy. So this is very prevalent, and the likelihood in your offices is that you're going to see this presenting into your office at some point. Most commonly, these patients present with an older age, or it's most commonly in people with an older age, longer duration of diabetes, especially if they've had it for more than 25 years. Poorly controlled blood glucose levels, high levels of fat, higher blood pressure, and patients with diabetes who are overweight. Peripheral neuropathy is the most common form of diabetic neuropathy. It generally affects the ends of nerves first, starting with the longest nerves. And that's why we see patients complaining of often foot pain, burning in the feet. And after the feet are affected, we'll often see the legs affected as well, followed by the hands and then the arms. Usually it presents symmetrically, so on both sides, often in a glove stocking distribution, so the feet, legs, hands, arms. And the patients will complain of numbness, sensory loss, and nighttime pain. They can also have motor deficits, a loss of proprioception, and also if the autonomic nerves are affected, we'll see all kinds of autonomic symptoms as well, like bladder dysfunction, sexual dysfunction, vasomotor instability, all kinds of other autonomic symptoms. So what we're really looking at is symptoms that depend on which nerves are affected. Here's some examples of the symptoms that the patients will present with. They'll often complain of numbness, or a decreased ability to feel pain or changes in temperature, especially in their feet and toes, very common. A tingling or burning feeling. It could be a sharp jabbing pain that's worse at nighttime, pain with walking, and also just a generally difficulty walking because of muscle weakness. They can be very sensitive to even light touch. And finally, what you're going to see quite commonly are serious foot problems such as ulcers, infections, and deformities. Here's a picture of a Charcot foot, or a Charcot's neuropathic foot. And this is something we've seen in our clinic here. And what happens, of course, with these patients is that they have a loss of sensation. So they have a neuropathy that causes decreased sensation. They can't, for example, feel pain when they're stepping on foreign objects, sharp objects, and this ends up in trauma to their feet and they don't even know it. And ultimately, what we get is this progressive deformity of the feet and progressive damage to the ligaments, cartilage, and bones. And in this picture, that's what we're seeing. We're seeing low arches, the foot's becoming deformed. The right foot here is fairly swollen as well. And this is the kind of thing you're going to see. You'll see changes in the skin around the feet and legs as well. So once again, these patients have a higher risk of ulcers and infections. And also what happens with these patients is they're subject to all kinds of minor trauma like sprains, even things like stress fractures that they aren't even aware of. And over time, these small bits of trauma lead to this deformity in the foot with dislocated bones and cartilages, and they don't even know it's happening while their foot is becoming damaged and deformed. So on the left here we see a couple pictures. The top one is a patient who suffered from an ulcer because they didn't even know this was developing. They couldn't feel this ulcer developing. And most diabetic patients are told to check their feet on a daily basis to have a look. Don't depend on what they feel, but actually visually inspect their feet to see if they're developing calluses, infections, changes in skin, etc. On the bottom picture here, we're actually seeing a deformed right ankle. This is someone who suffered from a fracture, didn't even know it, and it didn't heal up properly, and they're left with this deformed foot. So you will see these types of things presenting in diabetic patients who are suffering from peripheral neuropathy. Why does this happen? What is the etiology of diabetic neuropathy? There's lots of different proposed reasons, but here are some of the key reasons that you'll find out there. The first thing is that these patients are exposed to high blood glucose, and that these higher levels of blood glucose do result in nerve damage. There's other metabolic factors too, like high blood fat levels or low levels of insulin that can also eventually lead to nerve damage. One of the key factors are neurovascular factors. In diabetic patients, we'll see damage to blood vessels, and because of the damage to the blood vessels, we'll have a reduced supply of oxygen and nutrients to nerves, and then eventually the nerves start becoming damaged because they're not getting the proper blood flow. Other reasons for the neuropathies could be simply a mechanical injury to the nerves, so they might be suffering from a carpal tunnel syndrome due to the pressure on the nerve. It could be inherited traits that make them more susceptible to nerve disease, or lifestyle factors like smoking or alcohol use. So here we're looking at vascular injury. We can see on the left side here a diagram of how nerves and the blood supply to the nerves are interrelated. In the top we see a healthy situation with blood vessels surrounding the nerves, and we have healthy blood vessels and healthy nerves. The middle picture there, we're looking at diseased blood vessels, and this is what will happen in a diabetic patient. They're shriveling away, and the nerve is not getting the proper blood supply. And finally, the bottom, it's resulting in damage to the nerves and all kinds of nerve symptoms and neuropathy. So the first pathological change you'll often see in a diabetic patient is vasoconstriction. So we're actually losing our blood supply to the nerves. And as the disease progresses, we're going to end up with something called neuronal ischemia. So basically the blood supply being cut off from the nerves, and then we have issues with the nerves and neuropathy. And what we're seeing with these patients is that if they're given vasodilator agents, so medications that can increase the blood flow to the area, they end up with substantial improvements in their neuronal blood flow and in nerve conduction velocities. And this is very interesting when we relate this to laser, because we know when we put a laser on a diabetic patient, we're seeing results. And this might be the reason. With the laser, we know, especially the 905 nanometer wavelength, we're greatly increasing vasodilation in an area. So if we put that laser over an area of neuropathy, that might be the reason, and likely is one of the reasons why we're helping these patients. We're increasing blood flow to the nerves, and therefore the nerves are healing and they aren't as susceptible to the damage because of the decreased blood flow. So this might be a factor in the success of laser treatments with diabetic neuropathy. So whenever you have your diabetic patient coming in, we have to do a proper assessment, and I won't go over this in too much detail, but we need to do a neurological exam and do a visual inspection. Our neurological exam will include nerve testing, motor, sensory, even cranial nerves, muscle strength. We're going to test our small nerve fibers and our large nerve fibers. So when we're testing small nerve fibers, we're really looking at temperature, light touch, pinprick. In this picture on the left here, we're looking at a monofilament test, which is a test that we're often using with diabetic patients to check their sensation. And to test large nerve fibers, one of the key tests is the test of vibration or using a tuning fork. We can also look at position sense, muscle strength, two-point discrimination. And of course, we've got to check our autonomic nerves as well. In terms of inspection, you're going to check the skin, the nails, calluses. So we're looking for hair loss on the legs or arms, skin or nail changes, including calluses, red areas, even look between the toes. So really do a careful inspection to see if change is happening in their feet. Also look for any deformities. You'll find a lot of these patients presenting with a fallen arch or low arch, their big toe will move over, so our hallux valgus, all kinds of deformities and swelling in the feet. Their toes will also end up being a little bit deformed in terms of hammer toes. So have a close look at their feet, and we want to follow this and make sure that there's not any kind of rapid change here. Of course, one of the standards are nerve conduction tests, and most of these patients will come in with some results from their nerve conduction tests. And one point of interest is, although the nerve conduction tests might be positive and show reduced functioning of the peripheral nerves, they rarely correlate with how severe the neuropathy is. So you can't depend on these tests to tell you how bad it is or what the patients might be feeling. It just serves as evidence that the nerves are being affected. So why laser therapy for diabetic neuropathies? There's lots of reasons we're going to use laser therapy for these patients. One thing is they will most often present with swelling and pain in the feet. And at a minimum, we're going to help reduce that swelling. And by reducing the swelling, the patient will be much more comfortable. They'll feel, their legs will feel lighter. They'll feel as though they can walk easier. And as a consequence of a reduction in swelling, they will have less pain. Another key point is with laser, we will repair tissue damage. And as I mentioned earlier, these patients often are damaging their ligaments and or suffering from fractures and all kinds of tissues in their extremities, and they don't even know that these tissues are being damaged. So the laser will actually help repair these damaged tissues that the patient is quite unaware of. And finally, what we're going to see is an improvement to skin texture and discoloration. So if you're treating someone for pain or swelling, indirectly you will also be treating their skin texture or any discoloration in the area, and they'll be quite pleased with this because sometimes it doesn't look very nice, and they're quite conscious of the changes in their skin. So that's another bonus, that they'll have a change in their skin. The skin will start looking a little more healthy and normal. So when we're treating these patients, there's many different approaches to treating them. There's not just one formula approach. You really have to find out where their symptoms are and come up with a good plan of action for them. And pretty soon I'll be going over some case studies, and I'll give you some ideas of how we set up treatment programs for the diabetic neuropathy patients. But generally, we might be treating over multiple areas. These might include the swollen areas, areas of pain. We might follow a nerve path if we know a specific nerve is involved. We might just treat or target the skin damage. And finally, you might treat wounds. Today we won't be talking too much about wounds, but we know that laser is very helpful in healing up wounds. So we recently actually ran a clinical study at Theralase where we took in quite a few diabetic neuropathy patients, and we treated them with a very set protocol to see how this would work and what kind of results we would get. And what we did is we treated these patients for 12 treatments. So our assessments were done within a 12 treatment period. We treated 4 locations on one side, and the treatments where we treated the patient was really dependent on their symptoms, swelling, and nerve signs. And what you'll see in front of you are the settings that we used for these patients. The first column we're looking at are standard settings. The other columns are for low BMI patients, high BMI patients, and dark skin. We had to change our settings for these other categories of patients. Most patients were standard patients, and we'll just go over some of these settings that we used. Up in the lumbar spine, we were using 80 milliwatts for 3 minutes using a multi-probe, and that's per point. In the buttock, we increased our settings because it's very dense, often can be dense musculature, a deep area, a lot of tissue to get through. We used 90 milliwatts for 3 minutes using our multi-probe. If we were treating into the thigh, we reduced our settings to 60 milliwatts, 3 minutes using our multi-probe. And then, of course, we're reducing our settings into the leg, foot, and toes. The leg was 50 milliwatts, 3 minutes using the multi-probe. Foot, 40 milliwatts, 3 minutes. And toes, we used our triple probe using our 30 milliwatt, 2-minute setting. So as the depth of the tissue was reduced as we came down from the buttock to the toes, we reduced our settings. Of course, the other categories of patients, we used different settings. Low BMI patients, The lumbar spine, we did continue to use our 80 milliwatts for 3 minutes. However, in the buttock, thigh, leg, leg, we reduced our settings. In the foot and toes, we maintained the same settings. High BMI patients, we generally increased our settings. And dark skin, we have to reduce our settings and increase our time so that they get the same dose. However, we don't run the risk of burning them or creating heat in the skin. So these are the settings we used. And what we do is we try to maintain these settings throughout the whole treatment protocol. We're going to look at a few case studies, and I'm hoping that this will give you some idea of how treatments were set up, the kind of results we were getting, and what the patients were presenting with. Our first case study, we'll call the patient Arnold, and here's his history. He was a 66-year-old male with a 40-year history of diabetes, so he was diagnosed many, many years ago. He presented with daily chronic numbness, tingling, and pain in his ankle and foot, especially on his right, although it was bilateral. His symptoms had begun 3 years earlier. Incidentally, he also suffered from gout, and he'd been suffering from that for 6 weeks in his big toe on the right. He was on medications for blood pressure and diabetes, and his VAS, or visual analog score, was 7 out of 10. So he was quite uncomfortable when he presented. On the examination, we found a decrease in light touch and pinprick sensation on both aspects of his right foot, the dorsal and plantar aspects, or top and bottom of the foot. Also along the inside of his foot, the medial foot, and the toes. His arches were low bilaterally, and he had presented with skin discoloration at the lower legs. We always measured the ankle circumference because most of these patients were presenting with a lot of swelling. And what we found was the right ankle to be more swollen than the left. It was 29.5 centimeters on the right compared to 28.5 on the left. So what we're seeing with this male was very typical of what we see with a chronic or long-standing diabetic neuropathy. The changes in the skin, the changes in the sensations, the pain, the swelling. These are very typical presentation. So we went on with our treatments. In this study, we were just treating one side, and it was very helpful to compare the changes on that side, and we kind of used the other side as our control, our untreated side. We treated his right foot only, 40 milliwatts for 3 minutes, using a multiple probe over 4 locations. Our medial and lateral foot, the top of the ankle, the anterior ankle, and the bottom of the foot, the plantar aspect of the foot. So we kind of worked our way around the foot and ankle. And here are our results. After the second treatment, he was already reporting that his pain was decreasing. By the third treatment, he was able to stand for longer periods of time. And by the sixth treatment, we were seeing improvement in the color in his legs. There was less swelling. The right ankle had come down to 29 centimeters from earlier it had been 29.5, and he was reporting decrease in pain. By the 12th treatment, his VAS score had come down to 5.5 out of 10. So what we're seeing is a general trend in decrease in his symptoms, decrease in swelling, and just basically overall he was reporting that he was much more comfortable. So we're quite pleased. Our next case study, we'll call this patient Sheila, 75-year-old female. She had been diagnosed with type 2 diabetes 25 years earlier, so also a very chronic case. She presented with a 2-year history of daily chronic swelling and pain in both her ankles, especially the right. The pain was felt very deep into the ankle. That's what was her chief complaint. She said it really hurt deep, deep into the joint. It was described as either being dull or sharp. Walking and standing were very difficult for her, and she was also experiencing tingling at the ball of her foot. We noted low arches on both feet when we examined her. She also had a bunion, so her foot was kind of becoming slightly deformed. Her ankle circumference was 27 centimeters bilaterally, and her visual analog scale was 7 out of 10. So she was also quite uncomfortable in a lot of pain. So once again, our treatment was 40 milliwatts for 3 minutes. We treated 4 locations. We treated the medial and lateral foot, the top of her ankle, and the ball of the foot because she was complaining of that tingling in the ball of the foot. We just treated one side. After 6 treatments, we already noticed that the circumference of her ankle was coming down. And this is a good point too. When these patients present to your office, be sure to get as many objective findings as you can. We always have a measuring tape around so we could measure it. And we usually also take photos so we can use this and keep these photos to show the difference in the change in circumference measurements. We can show it to other people as well. Now, unfortunately, she suffered from an ankle sprain on the other side, and that circumference went up, but we were treating the right side. We left the left side alone. After 6 treatment, her visual analog scale had reduced to 5.5 out of 10. Her swelling and redness had decreased. She had less pain and less tingling at the ball of her foot. By the 12th treatment, she reported 50 to 75% improvement overall, so she was quite pleased with the results. She had an improvement overall in all of her symptoms. The deep ankle pain had resolved, and her ankle circumference had come down to 26 centimeters. Visual analog scale all the way down to 3. So much more comfortable and a very happy patient. Finally, this is the last case study. In this study, for this patient, it was a little more difficult. He was dark-skinned and had much more progressed symptoms. And the reason why I say it was difficult because he was dark-skinned was the treatment was very, very long because we had to treat many locations and treat them for double the time to really have an effect. So he was in our clinic room for quite long periods of time. He was a 61-year-old male, dark-skinned, so type 4 meaning very black skin. He had been diagnosed with type 2 diabetes 4 years earlier. Now I would suspect that he probably was suffering from diabetes long before that because his symptoms were quite progressed, but he only came to understand he was suffering from it just the 4 years prior. He suffered from daily burning sensation in the front and back of his leg and the dorsum or top of his foot, both feet. He was complaining of poor balance. He was having a lot of difficulty walking, and his feet felt overall very heavy. The cold temperatures really aggravated his condition, and he'd already been through 2 years of physical therapy. By the time he came to see us, he had stopped the physical therapy, but he'd been through quite a bit. On examination, we found a lot of changes. The right ankle dorsiflexion and helix or big toe flexion was 4 out of 5, so it was reduced. He had a little less muscle strength there. On the left side, his symptoms were much more progressed. The left ankle dorsiflexion was only at 2 out of 5, and the left big toe or helix flexion was 1 out of 5, so his big toe on the left was not working very much there. He didn't really have any strength. We had a hard time eliciting his reflexes on both sides, and he was in a lot of pain. His visual analog scale was 8 out of 10. So this was a more involved treatment. In this treatment, we followed over the path of the nerves, over the sciatic, tibial, and peroneal nerves. We can only treat so many spots, so we tried to select the locations we thought would work best with him. We treated over the back of his leg. So once again, we reduced our power settings but increased our time. So in his right posterior thigh, we were treating 30 milliwatts for 6 minutes, very long treatment time. We moved into the back of his leg at 25 milliwatts for 6 minutes. And then we followed along the peroneal nerves, the right lateral leg, 25 milliwatts for 6 minutes. The front of the leg for 25 milliwatts, 6 minutes, and finally into the top of the foot, 20 milliwatts, 6 minutes. So he was here a long time. But we did achieve some good results. After 6 treatments, he reported that the burning sensation was less frequent. His legs felt lighter. He didn't get that heavy feeling anymore. At that point, he was 25% improved, and he was quite pleased that his walking was a lot easier. As I recall, the first time he came in, he was using a cane and was very dependent on that. But we really saw a change in his walking within 6 treatments. Also, climbing stairs was a lot easier. After 12 treatments, his visual analog scale had reduced by half, so 4 out of 10. His walking had improved, and he had a decrease in pain and numbness. So once again, he was quite pleased and was doing quite a bit better by the time he finished up his 12 treatments. So that's my information, but now I'm going to let you listen to some patients who've been into the clinic who are suffering from diabetic neuropathy, and they're going to tell you a little bit about their experiences.
being diabetic, you know, there's so much complications. Like especially going down to my feet. Well, I think anybody with diabetes will have this kind of problem. My both feet are very, the circulation is bad on both feet, but worse on my right foot. If you look at both feet, you would find that my right foot is even darker than my left because of the circulation. It's worse on my right foot than on my left. It's more tingling, more burning, more pain, more swelling. Well, this was the first time I ever had treatment like this, and I would say it was very, very successful. But my feet, it was my right foot, the treatments were on my right foot, and the swelling has been lowered quite a lot. The pain that I had are not as much as I used to have it. So as also the tingling. I do have them, but not as much. I say like about 40% less than when I came in here.
I came to the clinic because I am diabetic and have sore feet, and I am about to go on a trip. So I thought that I would try the laser therapy because I am going to do a lot of walking and hope to have a lovely holiday. I had very sore feet, and I had swelling in my feet, and I also had sharp pains occasionally, and I had very sore toes. The treatment has been very good for me. It has taken a lot of the swelling out of my feet. It has also taken a lot of the discomfort away, and I am able to walk much easier. I also have a sprain in the meantime after I started here in my left ankle, and it was very, very uncomfortable, and I have had 4 treatments on my ankle, and it is just about healed. So I am very grateful for that. I have been able to do much more walking than I have been doing in the last 2 years. I do not have the same discomfort, and I am very happy to be going on my trip because I didn't think I would be able to do that.
Well, I have diabetic neuropathy feet, and there's excruciating pain, tingling, sometimes numbness, and then I would get sometimes sharp pain that's in the through my toe and foot and torso, and my walking ability was very limited. Sometimes if I walk too far, I'm taking too far. I think I have about 12 treatments. I think so, yeah. And the first initial ones I was basically adjusted to the therapy and the medications. And so after that was resolved, I found that they were working on one foot, and within the 3rd or 4th treatment I started to feel different results. And the fact that my foot would feel lighter as opposed to my right foot. And then after the treatment continued, it seemed to reflect from one foot to the other, so it was like balance the other. Well, with my symptoms, the sharp pains I used to get frequently almost disappeared, which was great for me because, in the middle of the night I get a pain and I get like this. And I was able to do more walking, and the numbness and the tingling in my feet was really good.
I have neuropathy, which is a condition from type 2 diabetes. It affects your nerves, your feet, and your legs. That's your neurologist. and he diagnosed me having neuropathy from my diabetes, and there's the only thing that he suggested was to keep moving, exercise. The cold laser treatment is fantastic. No pain. My left leg has come alive. It's feels very energetic compared to my right leg. I have a lot more energy since the cold laser. I want to walk more. I want to do more things. I'm not losing my balance as much on my left leg. I'm losing it more on my right leg. Swelling has gone down in my toes. So one shoe fits better than the other. It's just amazing, the cold laser. It's such a difference.
Well, that I'm sure a lot of the information that these patients provided just reinforced some of the things I was telling you earlier. The patients will see a lot of change in their function. Their walking will greatly improve. Their general comfort level improves, and we see really good results. What we don't have are a lot of really good studies right now in this area. We have a lot of studies on laser healing nerves or affecting neuropathies. There's a large body of work on that. But studies specifically on diabetic neuropathy, there aren't a lot. However, I'm going to present you with a couple that show very good trends in the research and kind of validate the need or validate this road to increasing the research in the area. So this first study here, we're going to go over a couple of them, is called Low Intensity Laser Therapy for Painful Symptoms of Diabetic Sensory Motor Polyneuropathy, a controlled trial. It was actually done out of Toronto General Hospital, and it was a great study. The only problem, from what I understand with this study, is that it was cut off early because of funding. So they didn't get to do the whole study. They did enough to write up a report, and as we'll see in a second, there was a very good trend happening. Unfortunately, it wasn't followed all the way through. So their objective was to determine whether low-intensity laser therapy relieves the pain of diabetic sensory motor polyneuropathy. This was a randomized double-masked sham therapy controlled trial. They treated 50 patients with painful diabetic neuropathy. All the patients started off with a sham therapy, so they used a laser that wasn't really emitting any laser light, and that was done over 2 weeks. And then after that 2 weeks, they randomized the patients to receive biweekly sessions of either sham or laser therapy for 4 weeks. In terms of the laser treatments, they were done with a 905 nanometer wavelength of light, 60 milliwatts, 5 minutes per site over 2 sites. So they didn't treat too many locations, only 2 locations. As you saw in our clinical study here, we always treated at least 4 locations. And in their study, they were mostly applying the laser to pain along the sole, the bottom or the top of the foot. Of course, our study was a bit different. We were treating more areas around the ankle, the foot, and even into the leg. Their primary outcome measure was on the visual analog scale, so they're really looking at pain reduction. So what they found is both groups, the sham group and the laser group, or all patients experienced some decrease in discomfort during the sham treatment. So the first 2 weeks when they were all getting sham, they all were feeling a bit better, so there was definitely a level of placebo there. But after that, they split the groups for 4 weeks into sham or laser. And what they found is that the laser group continued to improve more than the sham group. So there was definitely a difference happening here. There were other things they wanted to retrieve, other information from the study that they were unable to retrieve because they had to cut it short, and also they didn't have enough number of patients, which were some of the more objective findings, like the nerve conduction studies, the sensory testing. So there is more other information we want to get out of these studies. Unfortunately, this one was cut short. But in terms of the pain, they really did see a difference between the laser and the sham. Their conclusions were that they observed a positive trend that warranted further investigation. And quoting the authors, we believe that further studies would be worthwhile because painful diabetic neuropathy is common. There are no significant adverse effects with the laser therapy, and the current pharmacological treatments are variably effective. I think they're trying to say that there's very limited help with medicine. So they really recommended to continue more studies with the laser. This next study is out of Serbia. It was called Influence of Low-Intensity Laser Therapy on Spatial Perception Threshold and Electroneurographic Findings in Patients with Diabetic Polyneuropathy. So they're analyzing the influence of laser therapy, once again, on spatial perception threshold and on ENG parameters on these patients. This study was from 2007, so not very old. They looked at 45 patients with clinical and ENG signs of painful diabetic neuropathy and divided them into a laser group and a control group. The laser group had 30 treatments, so quite a few treatments over 12 weeks, so that's a good amount of time. Before and after the treatment, they looked at certain parameters. They looked at motor conduction velocity and sensory conduction velocities of the peroneal nerve, tibialis nerve, and median nerve. And they also looked at tactile circumferential discriminator, so like 2-point discrimination, actually on the big toe. Although this picture here shows it on the finger, they're looking on the big toe. And their conclusion was that in the study we found significant change in the spatial perception threshold and an increase in the motor conduction velocity after laser therapy, indicating a favorable result by the treatment in patients with this condition. In our opinion, these results need further investigation. So I guess the bottom line here is that there are some good studies, not enough, and certainly further investigation is warranted. So we hope to see many more studies coming out in this area in the coming years. Thank you very much for attending this webinar. I hope you were able to gain some good background information on diabetic neuropathy, some ideas for how we might treat it, and an understanding of how successful this can be for your patients and can really help them out with their discomfort and condition. We have some upcoming webinars and events I just want to let you know about. February 16th, there'll be a webinar on laser marketplace. So we're going to be looking at different lasers out in the marketplace and how to compare them. March 12th, we'll be running an 8-hour seminar in Calgary, and March 22nd will be a webinar on the indications and contraindications for laser therapy. We're almost always asked for copies of our webinars, and if you'd like one, please be sure to complete and return the feedback questionnaire that will automatically be sent to you after this webinar. So once we get that questionnaire back, we will automatically send you off a copy of the webinar. Now I'm going to take in some questions. So if you have some questions, just take a few minutes to type them into the sidebar, the questions sidebar, and I'll try to get to as many as I can in just a minute. Thank you. Okay, so I'm going to start going over some of these questions. Where would you treat on the foot if the patient has a history of melanomas and other skin cancers? Or would you not even treat a person due to possible cause of cancer? Well, by the book, we don't treat any patients who have a history of malignant or benign cancer. So really, we shouldn't be treating those patients. Did the studies look at long-term benefits? The studies I saw, these two that we came up with today, I didn't see any long-term follow-up in those. They were really looking within the treatment period. Okay, any concern of dosage if the patient is already on pharmacological drugs such as Lyrica or gabapentin? I have treated several patients who are on these medications, and I've not found any problem with those medications. So what you might want to do the first number of treatments to be really safe is cut your dose down to 50%. So they should only get a half dose, and make sure that they're not getting any complications or any aggravation, and then slowly over the next few treatments increase their dose to 100%. So that's your safest way, but I will tell you that from my experience I've not seen any problem with those particular medications. Thank you very much for attending, and I'm sorry if some of you had difficulty hearing some of our patients on video. We'll try to get that resolved for our next webinars. Thank you and have a great day.